From the medical approach to manage CRPS, some medications, there are many approaches that we can use for medications. And again, this is purely just for description. Every person is different. I might see somebody in front of me that's had intolerance to one or two medications, so I need to adapt the medications, change the medications. But there are some broad things that we can do. This is a neuropathic pain condition. So you need to use neuropathic pain medications, anti-neuropathic medications. The gabapentinoids can be very helpful. Pregabalin, gabapentin. Studies have shown gabapentin to be more useful in CRPS than pregabalin. The discussion about those two anti-epileptic, anti-neuropathic medications can be vast. There are pros and cons to each. Sometimes it's more favorable to use one over the other. If one doesn't work, it doesn't mean the other's not going to work. So there are many medications that you may need to work through to get a good dose, a good medication that you can tolerate well. Remember, if you can treat CRPS early, these medications are not going to be long-term. You want a short, sharp burst of pain management so that the conservative therapy can happen and we can get that part of the body moving again and integrated within the nervous system. Tricyclic antidepressants, this is not for depression, but for pain. It helps sleep if sleep is a problem, and neuropathic pain definitely affects sleep at night as well. The so-called SNRI medications can be helpful, the duloxetines, the venlafaxines, the desvenlafaxines, that can be very helpful. Sometimes these medications in combination can be helpful as well. So these are the oral medications, and you need to see a patient. Patients should be seen almost weekly until you get on top of things. There is no point in saying try these medications and come back when you're ready. You need to be proactive. Treatment approaches need to be aggressive and proactive. You need to get the medications right. Work with the surgeons, work with the general practitioners, work with the OTs, work with the physiotherapists, really work together as a team. Remember, the aim is to get that body moving again. In these instances, whilst opioid medications are again another discussion, in these instances a short burst of good analgesia, sometimes even with opioids, may be helpful, but for a very short time. There is a reason for using it, and it's to get that body moving again. We use quite a lot of topical medications, so if it's a small area, so imagine just a wrist or a hand that is hypersensitive, we can use topicalized local anesthetic. We can use topicalized medications like ketamine. We can use topicalized medications like clonidine, amitriptyline, and there are many others that we can compound into a paste that patients can apply to the area that can help desensitize. And remember, applying the cream in that area can sometimes even act as a means of desensitizing. In some instances, we might use intravenous medications like bisphosphonates, which are quite good anti-inflammatories in some forms of acute CRPS. And sometimes we can even use intravenous infusions like ketamine, lignocaine, and as mentioned, bisphosphonates. One of the ones that I haven't mentioned here, and I think it is very important, it is one of the cornerstones of acute CRPS, is prednisolone, steroidal anti-inflammatories, because if I go back to that slide on mechanisms, this is a neuroimmune problem, it's an inflammatory problem, it's an autoimmune problem. Steroidal anti-inflammatories can be pinnacle, key, movement saving in acute early CRPS. There are pros and cons to having steroids, no doubt about it. But again, if you've got somebody that knows what they're doing, you've got a patient that you've educated, you have a plan, you're working with a primary practitioner, you're working with a general practitioner, steroids can be vital in just getting things going again. So there are many things that you can do with medications, and again, it depends entirely on that person sitting in front of you, because every single body is different. The interventional approaches for CRPS are also very important because they can allow you a window of opportunity, a window of analgesia, and a window of good analgesia in some cases, where you can really focus on those conservative treatment approaches. You can really get the physical therapy happening, the occupational therapy happening. It can help reintegrate that hand, that limb with the nervous system. So sympathetic ganglion blocks can be considered, where we put local anesthetic, we put some steroids. Sometimes we even use Botox or clonidine in the sympathetic ganglion to provide more prolonged and more dense pain control to allow functional rehabilitation. I've never used phenol in a sympathectomy for CRPS. I've never needed to. I certainly would maybe consider it in the right circumstances. Phenol is generally used in elderly people with osteoarthritic joints that are too severe for surgery, or people are too old or too frail for surgery. Phenol is used in those circumstances, and phenol has been originally used in the cancer pain area of pain management. Neurostimulation is a means of using technology to target parts of the body and focus therapy on a defined target, so electrically stimulating some of the nerves, which can absolutely help manage complex regional pain syndrome. It can help manage severe refractory CRPS. So spinal cord stimulation has been shown to be helpful, and as has dorsal root ganglion stimulation and even peripheral nerve stimulation as well. So nerve stimulation, neurostimulation, neuromodulation, these are terms for the same treatment approach, and that it's using electrical stimulation to manage severe refractory CRPS. It is a therapy that should be considered, particularly if patients are failing conservative measures, if patients are failing medications. And in some instances, you might even consider it early. There have been some publications calling for early utilization of CRPS. If I can give somebody good going pain reduction, balancing out pros and cons, risks versus benefits, good going pain reduction, that might be enough to get them mobilizing again. I can think of a story where we had a relatively young person, a young lady with CRPS of the foot, and she was in school, university, really wanted to get her exams done, and she was in a terrible phase of CRPS. Nothing was working, and we utilized a neuromodulator temporarily for 2 to 3 months, just so that we could allow intense physiotherapy and rehabilitation, and that worked. It got the person through the exams and through the defined life stressor that we needed to. So there are different ways of utilizing these therapies, and again, it's just a list of treatments, but you've got to adapt it to the person sitting in front of you. Another approach to CRPS might look something like this. If you've got acute CRPS, so somebody with early CRPS, the full-blown red-hot swollen CRPS, you're going to get an early referral, as I've mentioned, a multidisciplinary approach, physios, OTs, psychologists even. The physical is a very important part of it. It's the motor imagery, it's the movement, it's the desensitization, it's the mirror therapy. The psychological approach is very important as well, because fear becomes a factor. Understanding becomes a factor. This can trigger depression, anxiety, unknown. So it's important to bring in psychologists at the right time. I've mentioned opioids. Opioids we know can be detrimental. I've previously said sometimes you can use opioids for a short burst, but if somebody's on a lot of opioid when they see you and they're in acute CRPS, they're unlikely to improve until that opioid dose is controlled. Smoking can make things worse. Alcohol can make things worse. Caffeine can make things worse. PTSD can make things worse. So you can see how you've got to assess that person in front of you. It's got to be an early assessment, a comprehensive assessment, an open assessment as well. An approach might be to focus on the pain processing itself, as I've mentioned. So you focus on pain management. You focus on the autonomic component of the condition in front of you, and you focus on the immune component in the condition in front of you. So gabapentin, PEA, which I haven't mentioned before, palmitoyl ethinyl amide, may provide some additional benefits. Ketamine, compounded cream. There are different compounds that we can make up depending on the person and the type of CRPS sitting in front of you. We can use nerve blocks to the dorsal root ganglions, all about pain processing and pain management. We can use pulsed radiofrequency to the dorsal root ganglions because we know that's an important factor for neural conduction within the DRGs, within the nerves close to the spinal cord. We focus on the autonomic aspect. If somebody's autonomic system is highly heightened, pulsed radiofrequency to the sympathetic plexus. Remember, you block the sympathetic plexus, you block parasympathetic, you change the relationship with the parasympathetic sympathetic nervous system. I want to dial down the sympathetic nervous system in acute CRPS. Sometimes something as simple as slow breathing. You stop 4 or 5 times a day. You take 10 to 20 slow breaths. You can do it right now and see how it changes your body. And it does and will and has been shown to change your body. Something as simple as deep breathing. You've got to focus on the immune aspect. Remember, as I've mentioned, steroids, bisphosphonates, vitamin C can be helpful. Some anti-inflammatories like aspirin can be helpful as well. So there are a number of aspects that you can adjust to the patient. There's a lot of medication that I've just mentioned. If you're going to give this medication to somebody that hasn't been on much medication, you need to see them often. They need to be seen often to make sure you're not giving them side effects and you're managing things in a proactive fashion. How about chronic CRPS? Remember what I said, we see people with acute CRPS, but we see way too many people with chronic CRPS because it means somewhere along the way they've been misdiagnosed, they've been forgotten, they've been put aside and told there's nothing that can be done. I had a lady with a wrist fusion. Surgeon said, "This is your calling, you're going to have pain for the rest of your life. You need to take 50 milligrams of morphine a day," which she did, and I saw her 6-7 years after that. She's now off all medications, she's working well with our team, she has had a form of nerve stimulation applied, and she's now enjoying a phenomenal quality of life again. Back playing the piano. It is possible, even chronic CRPS, but you've got to have those key approaches, a team, experts, and a step at a time. So chronic CRPS is different. You need to use a multidisciplinary team. You need to use physiotherapists, you need to use psychologists, but what they do might be a little different to acute CRPS. Opioids are a factor. Smoking, alcohol, caffeine, stress, PTSD, all those things are a factor, and if they're there, you need to be addressed. Medications don't work as well. Sometimes we need to use intensive, ongoing, long-term pain management programs. Sometimes we need to use repeated ketamine infusions, repeated lignocaine infusions. Nerve stimulation can absolutely be used in chronic CRPS, but studies have shown if you use nerve stimulation more than about 10 years after the diagnosis, it's unlikely to help because that neuroplasticity has locked in. So again, different times of the disease require different treatment approaches.